Hi, thanks so much for being here and for having me here as well. I want to share a little bit about my journey in developing EveKit, which is a system for enabling women to screen themselves at home for HPV and other sexually transmitted infections. So I'm not a researcher, and I don't have a healthcare background. My journey actually started here at OCAD, where I studied industrial design. And I have to say, I'm very excited to see that several of these projects are using the design process. That makes my heart very warm. And this started with a conversation that I had with these women who are my friends. So basically, we were having a conversation over coffee, and somebody said, I have to get a Pap test. I know I've been needing to get a Pap test for years, but I haven't done it yet because I find it uncomfortable. And this started off sort of a wave of, heads nodding around the table and acknowledgement that this is something that is uncomfortable. And so we started talking about, well, how big of a problem is this really? You're not going. What about other people? And so I looked into it a little bit further, and I was surprised to discover that actually 1 in 3 women in Canada, in Ontario, it's almost 40% of women, are not screening on a regular basis for cervical cancer. And what this means for us as a country, a developed country with largely organized screening, is that we still have 4 women a day who develop cervical cancer and 1 woman a day who dies from this very preventable disease. And so when we looked into the research to understand why some of these women weren't going, we found a lot of things, both from our primary research talking to women, but also through the literature. And these are some of the reasons that people don't go. So it could be that there is a stigma. This is actually especially true for sexually transmitted infections as well, not just for cervical cancer. It could be a cultural issue. Discomfort, embarrassment is actually surprisingly high. It could be a logistical issue, inconvenience, distance, or I can't take time off work. I have children, I don't have childcare. Or it could be a lack of primary care. I don't have a doctor, it's too far away, what do I do? And so these are some of the issues that we were coming up against in our research. And so we started thinking, well, how do we solve some of these issues? How do we make an experience, wrong button, that looks like this, as illustrated by Lena Dunham from Girls, into something a little bit more like that. So it's not necessarily so relaxing, but something that's more accessible, more convenient, and something that people would be willing to do, especially if there's some emotional barriers there for those women. But of course, there are challenges to any problem. And so we started thinking about what are the challenges in terms of making a solution that would address this. One is obviously the challenge is how do we create more accessible alternative to in-clinic screening? The second is we wanted to make sure that patients would know how to do this correctly because they would be on their own. They wouldn't have any access to supervision or a professional with them. So it had to be really, really clear what they needed to do. And thirdly, it was very, very important for us to understand how these patients would link back into the healthcare system because, again, they're on their own. And these are the risks of providing care to somebody who's not immediately in front of you. And so going into that, fast forward through all of the development, I'm just going to tell you what we did. Self-sampling came out as one of the very promising ideas for how to get women to collect their own samples, specifically for HPV, which is a virus that causes cervical cancer, as well as STIs. So this was very clear. This is not our research, but what we found was it was comparable to a physician-collected sample, actually more sensitive than a urine or a physician-collected sample for chlamydia and gonorrhea. For HPV, there's a slight decrement from the physician-collected sample, but it's still more sensitive than a PAP. It was very acceptable to patients. A large majority, like 70, 80% of women, depending on the study, said that they would prefer collecting their own sample compared to the doctor. It increased participation rates compared to invitation letters in underscreened populations. So this was something that we saw as being very, very promising. So in general, there was sort of a consensus around this being a good strategy for increasing screening, especially for those who weren't already participating in a traditional clinic-based screening program. But there were some problems with this. First of all, patients who said they would prefer to collect their own samples didn't necessarily feel confident that they would be able to. So the research was indicating they wanted to, but they didn't know how, and they were worried they were going to do it wrong. Secondly, a lot of this research was done with, a standard swab like this one here, and these are really designed for a provider with a line of sight. It's not designed for somebody who has no training to say, insert this 3 inches, turn it 5 times. What's going to happen is everybody does it differently, and then you don't have any consistency in the samples that are being collected, and they don't feel confident in the samples that they're collecting. And finally, it doesn't consider that healthcare context around the patient, which is what I mentioned was the third challenge that we were really concerned about. So our solution was 2 things. One is the HerSwab device, which we designed, developed, that you can see here on the left, and then the other is called the EveKit system, which is more of an online application that we developed. So how it works is, first of all, a patient would obtain a kit, and this is what the kit looks like here. So I have demo. So they would either order this online or they could receive it from a location that had them available and then register it online, create an account. On the provider side, they would approve their intake. So one of the things, again, we wanted to ensure was that the patients who were using the system, it was appropriate for them. So what we built into our tool was an eligibility assessment. So those questions ask things like, are you pregnant? Do you have any symptoms, et cetera, et cetera. And if there were answers that were concerning, we would tell them right away that you need to go see a doctor. You can't do this methodology. And so that's very important for the provider. Every patient that goes through the system that meets the eligibility criteria is connected with one of the providers that we work with, so there's always oversight of each of the patients that goes through. A digital requisition form is created for that patient, and then the lab receives the requisition form. And we're currently working with Mount Sinai's hospital lab right now. So secondly, they would have the kit. They would collect a sample at home using our HerSwab device, and I have a little video here to show you how it works. So here, the patient receiving their kit at home. Inside of the kit, there's instructions, there's a collection device, and there's a sample preservation bag. So very, very simple. This is how you use the device. You insert the white tip, very much like a tampon. You turn the handle until it stops, and that extends and rotates a swab on the inside. Put the swab back with the sample into the box. The box is already prepaid, so then you just drop it off in the mail, and that goes directly to the lab where they process the samples. So the sample is sent, the lab receives the sample, they already have a requisition form, so they can go ahead and do that. If there is a positive result, in the case of chlamydia gonorrhea, they do any reporting as well. And then if there is and then they upload the results to the online portal, patients are notified, they can see their results, they're connected to educational materials. As long as they're looking at a computer screen, we want to load them up with education and make sure that they understand their this information regardless of whether the results are positive or negative. And if there is a positive result, then the physician contacts the patient by phone, counsels them, and talks to them about what happens next. In the case of a chlamydia gonorrhea, they can send a prescription form to their nearest pharmacy as well, so that they can pick up medication. So that's how the system works, and that's just a really quick overview of what we've done. So far, we've been fortunate to work with some academic partners, because again, we are not researchers, to do several studies. And so far, what we have found is with the HerSwab device by itself, we've had high agreement with physician-collected swabs for HPV. We've had good agreement with physician-collected swabs for chlamydia, gonorrhea as well. 93% of our participants said that the swab was very easy or easy to use. And actually, it's not up here, but a lot of patients also specified that they thought the perception was that this device would collect a better sample than a standard swab, which is what we were aiming for. We have a very low sample error rate, so around 1% or less compared to 4% for PAP. It is Health Canada licensed and HIPAA compliant as well now. And we also are working on several pilots with other research collaborators in Ontario, BC, Newfoundland, and internationally as well, with underscreened women in rural locations, immigrant, newcomer women, as well as Aboriginal women as well. So I have here a quick lessons learned slide, which is not on here, I think, but I'll just give you a few points for what we've learned. Even though at the outset we thought this was a very simple solution, as a new grad, I looked back on our first business plan and I thought we were going to get this done and in market in 6 months, which was not the case at all. It does take a huge amount of time and effort to build. And the thing that we've learned is that every stage is actually the hardest. Every time we pass a milestone, we think that it's going to get easier, but actually it comes with a different set of challenges. And I think that innovators need to be prepared for that. But having said that, we are so fortunate to have worked with champions within the academic community who have worked with us to demonstrate our project and believed in what we were doing enough to take it forward. Feedback, absolutely so important, as has been demonstrated by the design projects that have been talked about already. And finally, for us, persistence is absolutely critical. And the thing that has really gotten us through, which I'll share with you, is the women that we talked to. So here are a couple quotes. One is from a woman the top is from a woman whose best friend died of cervical cancer because she had vaginismus and was unable to get Pap tests even though she tried multiple times. By the time she finally got one, she was very late stage and unfortunately died. So she says, "I wish something like this existed a decade ago so that she could still be here." The second quote is from a project that we did in Colombia in the Amazon region. So these are very remote places where it's very, very difficult to access. They screened women and they found a mother-daughter who both were high risk for HPV, and it turned out the mother was diagnosed with cervical cancer. And they said, my mother was diagnosed with cervical cancer. In less than a week, she was transferred to Bogota. Fortunately, it was in time, and she was able to start chemo. And I think this is really critical because I don't know what would have happened to this woman had she not been screened using this in that particular project. So, all to say, these are things that keep us going, and we believe in what we're doing. We are always looking for collaborators and researchers and other people who want to join us on our mission. And so our tagline is, "Let's get more women screening together." Thank you.